This is the fourth in a series of presentations on radiography of joint disorders in veterinary patients. The intent of this presentation is to describe and provide examples of the most common manifestations of osteochondrosis in the dog. And by the end of the presentation, I want you to be able to list the sites of osteochondrosis, list which radiographic views are the most helpful for each site, and be able to identify, describe, and diagnose osteochondrosis in the dog in the affected joints. Pay close attention to the exact location of the lesion in each joint. This is something you should commit to memory so that you know where to look when evaluating a patient with joint disease. Osteochondrosis affecting the shoulder is the most common manifestation in the dog, and important to note that the lesion develops in the caudal humeral head. Clinical signs in the patient will develop between 4 to 8 months of age, and this typically affects large and giant breeds, with males being affected more often than females. Keep in mind that both shoulders are affected 50% of the time, so if you identify it in one shoulder, it's a good idea to recommend radiographs in the other shoulder. This slide lists the radiographic findings that we might identify. Using the image on the right, the most important thing is to look for the articular or subchondral defect of the caudal aspect of the humeral head. So the humeral head is this portion right here, and it's going to be in the more caudal aspect of that humeral head. Along with an articular defect or contour abnormality, we sometimes see some associated subchondral lucency. And then the bone around that defect oftentimes has subchondral sclerosis or increased bone opacity. When you look at the normal humeral head, you'll notice that this subchondral bone in this area should actually look very similar to the subchondral bone of the tubercles. So compare how there is just a thin area of compact, opaque bone, and then a more lucent area with trabeculation. So this is markedly abnormal. We can look for an osteochondral fragment that we might identify on radiographs. This patient does not have one, but if we do identify that, remember that we will be able to make a diagnosis of osteochondrosis dissecans. The cartilage flap or chondral fragment that is oftentimes identified on arthroscopy is not going to be evident on radiographs because remember that is soft tissue opacity and we're not going to be able to identify it until it actually mineralizes. I do want to point out a normal structure, which is this round soft tissue opacity that has fat opacity around it, and that is actually an end-on vein, probably the caudal humeral circumflex vein. We don't want to confuse that with an osteochondral fragment. Here is that same patient without the labeling on it. Again, the articular contour defect with subchondral sclerosis. This patient does not have any secondary osteophytes on the caudal scapula or caudal humeral head. And then just for comparison, this is a normal shoulder, the lateral view. Again, smooth margin here of the articular surface, and then the opacity of this humeral head is very similar to the opacity of the tubercles. This is a different patient that has an additional finding. This one has a more subtle kind of lucency in the subchondral bone with a subtle flattening of this caudal articular margin. Quite a bit of subchondral sclerosis of this humeral head. Again, pay attention to where the lesion is. This is really important. This is the location. You're not going to identify it somewhere else. But in this patient now, we can see this curvilinear mineral opaque osteochondral fragment, and this has arisen from this cartilage defect, and then it has migrated into the most common location where we'll find it, and that is in this caudal aspect of the shoulder joint. Again, it does not want to be confused by this soft tissue opacity, which is our end-on vein. In the dog, these osteochondral fragments can actually migrate. The shoulder joint communicates with the bicipital bursa, so it is possible that this osteochondral fragment could migrate cranially and actually get into that bicipital bursa, and then it can actually be a cause of bicipital tendinopathy. What I want you to recognize is that all of these findings that we're describing are identified on the lateral view. The joint likely has some joint-related soft tissue swelling, but in the shoulder, it is very challenging to identify soft tissue joint-related swelling. If it were really severe, we might be able to identify it, but typically we do not. This is that same patient, just with more shaded labeling for your review later. This is a different view, or a different patient, same lateral view. This patient has a very large flattened region or defect in this caudal humeral head. Some surrounding subchondral sclerosis, not as much as the previous patient, and then a little bit of subchondral lucent modeling as well. When I look very closely at this patient, there is a very thin mineralized flap here, very thin osteochondral flap that we can see. So this patient then would have osteochondrosis dissecans. These are orthogonal views of a different patient that has osteochondrosis of the shoulder. In the caudal aspect of the humeral head, again identified on the lateral view, we see this flattened area with some subtle lucency and then surrounding subchondral sclerosis. This patient does not have any mineralized flaps that I identify or osteochondral fragments. Also has nice smooth articular margins, so no secondary osteoarthritis. The osteoarthritis is usually not identified in these young patients when they first present for their clinical signs, but will develop as they get older if we don't do anything about this. And sometimes we actually identify the shoulder osteoarthritis from osteochondrosis incidentally when we're taking thoracic radiographs in older patients. Please note that on the craniocaudal view, we can't see any of the abnormalities that we identified. The lesion is going to be superimposed here over the other portions of the humerus, so where the tubercles and intertubercular groove are, so we're not going to be able to identify the lesion. So keep in mind, in the shoulder, we want to find the lesion of osteochondrosis in the caudal aspect of the humeral head, and we're going to need the lateral view to identify the lesion. There is one additional view that is a variant on the lateral view that can be beneficial because it allows us to evaluate the caudolateral aspect of the humeral head. This is what is truly named the caudomedial craniolateral view, but is oftentimes called the supinated view. To obtain this view, the patient will still be in lateral recumbency with the shoulder of interest on the table. And then what we will do is we will rotate that elbow into a supinated position, which then also rotates the proximal humerus. We still obtain the view with the X-ray beam directed from above the patient to the image receptor within the table. On the left of the slide is the normal lateral view, and then in the middle of the slide is this caudomedial craniolateral or supinated view. And how we tell that it's supinated is pay attention to the greater and the lesser tubercles and the spacing in between. When we look at this supinated view, we can see that the greater and lesser tubercle are much more closely aligned because of the kind of obliquity of the position. Both of these views are totally normal dogs, so we don't see any signs of osteochondrosis. Elbow osteochondrosis is the second most common manifestation in the dog after shoulder osteochondrosis, and this lesion specifically develops in the humeral condyle and even more specifically within the medial aspect. So that is something to remember. Clinical signs develop typically between 5 to 10 months of age, and large breeds are again the breeds that are affected by elbow osteochondrosis, and oftentimes in the elbow it is actually the retriever breeds. As with shoulder osteochondrosis, males are affected more often than females. Osteochondrosis of the elbow is often bilateral, and osteochondrosis is a lesion that is part of the elbow dysplasia complex, and we will learn more about elbow dysplasia and all of its components in a future presentation. This slide lists the possible radiographic findings that we will look for when we are assessing for elbow osteochondrosis. And I want to tell you that these findings are going to be identified on the craniocaudal view. So remember that, keep that in mind. This is the craniocaudal view of the elbow. This is our lateral aspect of the elbow, and this is our medial aspect of the elbow, and you should be able to tell that from the location of the radial head and the ulna. This lesion, as I said, affects the humeral condyle, and it's within the medial aspect. So when I look at the craniocaudal view of this patient, I'm going to look for an articular contour or subchondral lucent defect within that medial aspect of the humeral condyle. So this patient has a subtle one, and most of the time these are pretty subtle. Associated with that, we most often see subchondral sclerosis, and this is a fairly moderate-sized region of subchondral sclerosis. If you compare this medial part of the humeral condyle to this lateral part of the humeral condyle, this is the more lucent opacity that we should see on this medial side. These patients will very rarely develop a radiographically apparent osteochondral fragment, and again, if that's present, we would diagnose osteochondrosis dissecans. This patient has very mild degenerative joint disease secondary to the osteochondrosis, and the mild nature is really this irregularity that is some early osteophytes forming on this medial epicondyle, and medial side is most common to find the degenerative changes because the lesion is medial. And then sometimes we'll see some osteophytes on the proximal ulna here near that medial coronoid process. Elbow joint swelling is challenging to identify, although it is more evident in the elbow than the joint swelling is in the shoulder. Here's that same patient with different shading for you to identify the lesion and then to see it on the radiograph without the arrows. Here is an example of a craniocaudal view of a totally normal patient. So we can compare that normal articular surface of the medial aspect of the humeral condyle and the more normal opacity with easy to see trabeculation of that medial aspect to the lateral aspect looking pretty uniform, and then nice smooth periarticular margins without any osteophytes. Here is a different patient that has a little bit different appearance of the osteochondrosis. Now this is a slightly oblique view, so this is our craniolateral caudomedial view, also called the pronated view, and I'll come back to that in a second. That allows for a little bit better evaluation of the medial aspect of the elbow joint. So this is medial here, and this is lateral over here. This patient has a flattened articular surface of the medial aspect of the humeral condyle, so that is not normal. Also has the subchondral sclerosis, that is the increased opacity of the bone. And then this patient does have that rare osteochondral fragment or joint mouse that we might be able to identify, and it is this small little linear osteochondral fragment. There's a little bit of irregularity to the medial humeral epicondyle, which is some osteophyte production, so this patient has some mild secondary osteoarthritis. This is a different patient that I did provide you the lateral view as well as the craniocaudal view, but remember that our osteochondrosis findings in the elbow are going to be identified on the craniocaudal view. So on this patient, there's a small articular defect here. Again, notice pretty subtle. So unfortunately, some of these lesions are really small, but can actually cause pretty significant clinical lameness. So a very small articular defect in that articular surface of the medial aspect of the humeral condyle with associated subchondral sclerosis. So again, this opacity of bone should be the same as the lateral aspect. Now on the lateral view, sometimes we can identify the joint soft tissue swelling that might be surrounding the joint, but unfortunately the reason we can't identify the osteochondrosis lesion is that it's going to be superimposed. So this is our condyle here, and it's going to be superimposed over the radius and the ulna, so we're not going to be able to identify that lesion. This slide demonstrates how to obtain that additional helpful view, that craniolateral caudomedial view or the pronated view. So the patient is positioned as for the craniocaudal view. And then usually what I do is just kind of push the shoulder over towards the other side of the patient. And what that will do is it will pronate that elbow. So now when the X-ray beam is directed from above the patient, it's actually directed into the craniolateral and then exiting out the caudomedial aspect of that elbow joint, excuse me. On the left of the slide is our standard craniocaudal view, and then on the middle of the slide is this pronated view or craniolateral caudomedial view. And again, what it does is it kind of takes the ulna away from superimposed being on that medial aspect of the humeral condyle. It actually allows evaluation of that medial aspect of the humeral condyle, and then when we talk about elbow dysplasia, it allows evaluation of that medial cornoid process, so it's a good view for that as well. Moving into the tarsus, osteochondrosis affecting the tarsus is the third most common manifestation in the dog. The lesion develops in the trochlear ridges or the ridges of the trochlear tali, and really almost entirely within that medial ridge. The lateral ridge is very rare. Clinical signs will develop in the 6 to 12-month-old patient. Again, large breeds are predominantly affected, and then oftentimes the Rottweiler and Labrador Retriever are overrepresented. In this lesion, males and females are equally affected. And then both tarsi are affected about 40% of the time, so just under 1/2. This slide lists all of the radiographic findings that we will assess for, and this lesion is best identified on the dorsal plantar view. I will show you the lateral view where we can look for it as well, but best identified on the dorsal plantar view. What we are going to look for is a lesion affecting, remember, that medial ridge predominantly of the trochlea tali. So here is our talus. We got to remember where the talus is. This is the calcaneus and the tuberosity. The lateral ridge is going to be superimposed by that calcaneus, so that can be challenging to evaluate when it is affected. But the medial ridge is over here and easier to identify because the calcaneus is not superimposed over it. We are assessing for mainly flattening or kind of an abnormal shape of that medial ridge. And when that happens, when we have a defect there or flattening, what is radiographically sometimes more apparent to our eye is that the medial aspect of that tarsocrural joint space looks wide. And it's not really that the joint space is truly the problem, it's that it is wider because we don't have that normal bone of the medial ridge. So widening of that medial joint space, and then when we look closely, it's because we have a flattened or abnormal medial ridge of the trochlea tali. And then this patient has a lot of subchondral sclerosis. There is intracapsular soft tissue swelling surrounding that tarsocrural joint, and that is much more easy to identify in the tarsus than the shoulder and the elbow. This patient also has secondary degenerative joint disease, so these are osteophytes, these irregularities on the medial malleolus, and these irregularities on the medial aspect of the talus. I'm going to point out the fibula and show that there are two smoothly marginated bumps on the lateral malleolus of the fibula in the dog, and that is normal. In this dog, I don't see any osteochondral fragment. If we did, we would identify and diagnose osteochondrosis dissecans. So this is that same dorsal plantar view of this patient that shows those findings without the overlying labeling. This is the lateral view of that patient, and I want to draw your attention to this pretty marked intracapsular soft tissue swelling that is on the plantar aspect of the tarsocrural joint. The joint pouch back here is quite large, and so this is quite a bit of soft tissue swelling. If we look on either sides of the slide, I gave you a normal lateral view of the tarsus and a normal DP view of the tarsus. This patient has much smaller amount of soft tissue on the plantar aspect of this tarsocrural joint, so compare the affected patient. On the lateral view, the area of the trochlear ridge that is affected is this kind of more proximal and plantar aspect. In this patient, I can identify that there's an abnormality because that part of the joint space is kind of wide compared to the normal congruent joint space in this dog. This patient has some osteophytes also on this caudal and distal aspect of the tibia, as well as the cranial and distal aspect of the tibia. But again, the findings are most easily identified on the dorsal plantar view. Let's look at this normal patient just to see what the normal medial ridge of the trochlear looks like. So it has a nice smooth bump on it and a very small and uniform joint space. So really easy to see the difference on our affected patient compared to the normal patient, and then what the normal subchondral bone looks like. This is a different patient with the lateral and the dorsal plantar views. Let's look at the dorsal plantar view first. I do see pretty marked intracapsular soft tissue swelling centered on that tarsocrural joint. I see that the joint space medially here looks abnormal. The abnormality is predominantly because we have what appears to be a more wide joint space here. It really is because this medial ridge of the talus is abnormally shaped and flattened. And if I look very closely, I can see that there is actually a separate piece of bone associated with that abnormally shaped medial ridge. And so that is our osteochondral fragment. So this patient has osteochondrosis dissecans. There is subchondral sclerosis of that medial ridge, and then this patient has some osteophytosis on the medial aspect of the talus. On the lateral view, I can see the intracapsular soft tissue swelling here on the plantar aspect of the joint and mildly on the dorsal aspect of the joint. And then again, we'd be assessing for the lesion in this area. I don't have a good example, but an additional helpful view to assess that part of the trochlear ridges of the talus would be a nice flexed or extremely flexed lateral view of the tarsus. Then that brings us to the stifle, and osteochondrosis affecting the stifle is the least common manifestation in the dog. And although it is the least common, it's important to recognize that this can happen and to rule this lesion out in patients that are presenting with stifle osteoarthritis or DJD. Especially you would want to identify this and rule out that the patient has osteochondrosis versus craniocruciate ligament instability. This lesion develops specifically in the femoral condyle and may develop in the lateral or medial femoral condyle. Clinical signs typically develop around 5 to 7 months of age, and large breeds, again, are predominantly affected by this, and I've listed several breeds that are overrepresented. And then, as with all the other joints, osteochondrosis of the stifle is often bilateral. This slide lists the typical radiographic findings that we can look for, and in the stifle, I feel that we can best identify these abnormalities on the cranial caudal view. This is an example of a patient that has a small lesion of osteochondrosis. In this cranial caudal view, first let's recognize that this is our lateral aspect of this stifle. So here's our fibula, that's at the lateral aspect, and this is the medial aspect. So in this patient, the lateral femoral condyle has a small articular defect and subchondral lucency, and then it has surrounding subchondral sclerosis. So this is a lesion of osteochondrosis. I do not see any osteochondral fragments, although those are oftentimes identified best on the lateral view. I want to remind you that there is a normal radiolucency associated with the lateral femoral condyle, and that is the extensor fossa, which is the origin for the long digital extensor tendon. This patient has this radiolucency over here at the lateral aspect, so not really the articular aspect. And then there is this thin sclerotic line around it. So that is normal. So please do not mistake this for an osteochondrosis lesion. Here's the same patient without any labeling, and then I want to compare it to this patient that is normal of a cranial caudal view on the left of the slide. This patient has a more extensive extensor fossa. I can see the extensor fossa out here at the non-articular area, but also this lucency that has kind of this thin sclerotic area is an extension of that extensor fossa. But this looks different than the patient with the osteochondrosis lesion. This is a different patient with a larger lesion, and I gave you the craniocaudal and lateral views. So on the craniocaudal view, again, I feel that we can find the lesion the best there. There is a large flattened region of the articular contour of the medial femoral condyle, so here's lateral over here, and then a large amount of subchondral sclerosis and a little bit of subchondral lucency. So this is a larger defect. On this patient's lateral view, we can actually identify that flattened area. So here's the normal articular margin of the lateral condyle. The medial condyle should have a similar appearance, but instead has this flattened area. The lateral view is going to be the view for us to identify the moderate intracapsular stifle joint swelling. I'm going to point out in this patient that this is the normal, still open physis of the tibial tuberosity. So we don't want to confuse that for a avulsion type trauma to this tibial tuberosity. And then this patient does not have any osteochondral fragment that I can identify. Here's the normal lateral view. Again, this is our normal amount of joint soft tissue with a normal infrapatellar fat pad compared to the patient that has moderate intracapsular swelling. Here's another patient with osteochondrosis lesion affecting the lateral femoral condyle. So in this patient, I see a smaller but more focally evident articular and subchondral defect in that margin of the lateral femoral condyle with surrounding subchondral sclerosis. This is a good example to compare what the normal subchondral bone should look like on the medial femoral condyle. On the lateral view, the lesion is more challenging, but if I look, I can actually see this little focal subchondral lucency in this part of the condyle, which is corresponding to the lateral femoral condyle, an articular defect. What we can see on this patient is quite a bit of intracapsular soft tissue swelling that is associated with this osteochondral defect. This patient is a little bit obliqued on this view. And then there may actually be a little faint mineral opacity here, and that could be an osteochondral fragment from this osteochondrosis lesion. And this is the typical location of those osteochondral fragments, although they could migrate into the caudal joint pouch as well. If you want to see additional examples or read a little bit more about osteochondrosis affecting the dog, please refer to the chapter and pages that I have listed here.